Welcome to the Center for Global Health Equity's final seminar of the 2022-2023 academic year. My name is Gary Harper. I'm a professor of global public health at the University of Michigan School of Public Health. Also a member of the Center for Global Health Equity's faculty leadership team and co-lead for the Empowering Women in Communities Challenge Group. And I'm very excited about being your host today for today's seminar. So just to tell you a little bit about the Center for Global Health Equity, the center is a place where colleagues from across the University of Michigan come together to create interdisciplinary actions to address our most pressing challenges in global health equity today. And just as important, we also welcome and celebrate our global partners who co-design and co-lead our work in many parts of the world. And because of things like Zoom, we can do that in a much easier way now and have amazing presentations like we do today. The theme for this seminar series is Journeys in Global Health Equity, Distances Traveled by Luminaries in the Field. These virtual conversations provide an inside perspective on the personal and professional pathways of global health leaders, and their stories inspire us to continue our collective work in advancing health equity. So who's in our audience today? Well, today we're joined by faculty, staff, and students from across the University of Michigan, Ann Arbor, and Flint campuses, as well as friends and colleagues from Kenya and around the world. All right, well, today we are very honored to have as our speaker, Dr. Amina Abubakar. Dr. Abubakar is a professor of psychology and director of the Institute for Human Development at Aga Khan University in Nairobi. Her work focuses on quantifying the neurocognitive burden of early childhood diseases, developing culturally appropriate psychological measures for use in sub-Saharan Africa, and identifying culturally appropriate intervention strategies for at-risk children. The neurodevelopmental tools and measures that Dr. Abubakar has contributed to developing has been used in more than 25 low and middle income countries. On top of all this, Amina is just an amazing human being. I've had the opportunity to get to know her in planning for this, and we'll be traveling to Nairobi in May, and I'm looking forward to having some time to speak with her. So now we're going to turn it over to Amina, and thank you very much for sharing your story with us today.
Thank you very much. Please give me a moment to just share my slides. So thanks everyone for coming for this seminar. I'm humbled for the invitation to do this presentation. I would just like to share my journey in this field because it wasn't always obvious that I would end up in global health for various reasons, but it's been a very exciting journey. Just to start with, I'm just a girl from a very small town. So if you see me struggling with technology, I'm trying to get used to it. I grew up at the borders of Kenya and Uganda from a relatively large family, 12 children and the 11th born. And some of the work I do is really very much, inspired by my childhood. Growing up in a rural setting, growing up in a family of 12 and being the 11th born, and growing up with a mother who had a disability. And yet always people ask, what has contributed to your success in settings where people might have assumed, there's a lot of odds to beat. And for me, key to that was really having a powerful, determined mother who, despite very many odds she faced in terms of physical health, limited economic resources, and raising many children, she was very determined that, especially her girls, she was very committed to girls' education. So quite a lot of the tribute to the work I do goes to her determination, and it really informs some of the work I do in the field of parenting, in the sense that when parents are motivated and when mothers have a clear vision of what they would like to, achieve for their children, most of the time, even in with very limited resources, they put in all to make it work out. So my early studies in Kenya, I started as a teacher doing a bachelor's of education. Back then, a bachelor's of education was not actually my choice of career. I wanted at first to be a lawyer because I really wanted a career that allows me to contribute towards protection of children's welfare. And I admired a few lawyers I had come across within our country who are really fighting for the rights of children. However, at that point, there was only one law school, so the options were very limited, and almost everyone who couldn't get into their degree of choice had to go to education because, again, at that time, there were only 2 or 3 universities in Kenya. It was a privilege in many ways for me to get to university because also I think for a Muslim girl at that time also to get into a setting of higher education, it was very rare. In our year, I can't remember exactly how many students were admitted, but I would say almost 1,000. There were only 2 Muslim girls. So quite a privilege to have started my journey as a teacher, and it still continues to advise the career I've had. I did go to do my master's at Kenyatta University. And at that point, literally, again, a question of limited choices. The only scholarship I would get is if I did a career in teaching Kiswahili. But while doing my undergraduate, I had the most fabulous teacher in psychology and in child development. She really inspired me. And therefore, I was keen to go into a career that would work directly with children. But at that point, then I couldn't get a scholarship. Yeah? So I funded my own master's degree to be able to go into the career I want. And it was quite a good way to fund it by selling in the markets. So getting fresh goods and selling so that I could fund my education. But the beauty about it is that Kenyatta University is the first time I actually had a brush with global health issues. So at that time, they had a really large multidisciplinary study funded by the Danish Health Foundation. It was called the Kenya-Danish Health Research Project. So it was funded by Danida. And this project wanted to look at the impact of vitamin A supplementation on maternal, newborn, and child health. And we had people from different fields, from those working in the labs to the nutritionalist. And there was also a psychology arm. And it was the first time actually as a research assistant within this project that I got to learn about neurodevelopmental assessment of children. And we were able to be trained by someone from Denmark using one of the global scales. And what was really interesting about these global scales, for those of you who know about how we assess child development for the very early years, it's really about the early emerging motor skills. It's all about language skills. It's all about, very basic skills as they emerge. So you can imagine we are working in a very rural part of Kenya, that is in Nyanza. And one of the tasks included assessing the child's ability to climb stairs. But because none of the homes there had stairs, we had to carry around stairs, mobile stairs, from house to house. And these places didn't actually have good roads. So most of the time, the driver would leave us somewhere along the way, and we would have to walk a few kilometers with our lovely stairs to be able to assess children. This would really be a very natural assessment in a high-income setting, because whether it's at home or in a clinic, one would expect to have stairs which children can climb and you see their motor skills. Now, not only was that quite a difficult task to do in terms of carrying around a heavy load, but also it was just not a culturally sensitive way to measure children. So because you're here measuring a child, not just on their ability, their motor skills, but you're actually measuring a child in terms of their newness, novelty, to add something they had not seen before. For some of the children, they would get very excited and want to try it. For some, it was a very scary experience. Now, I must say, regardless of the tasks and some of the issues being not very culturally appropriate, it was an eye-opening opportunity to work in a multidisciplinary setting, whereby although everything was geared towards understanding biomedical factors, we were able to really look in depth at neurobehavioral issues. So I would say that, the career I have now was never really my first choice, but it actually became my last choice in terms of what I would like to do, having experienced such a nice multidisciplinary team that was actually, advising global health priorities in terms of maternal, newborn, and child health. A few years after that, just a year or two, then the Cambridge Wellcome Trust, one of the leading health research institutes in Kenya, advertised for a PhD position. And the PhD position was actually funded by the National Institute of Health. And the key to it was to develop measures of early brain insults for children in low and middle income countries. Now, this was very novel because in many ways, back then, everyone considered scales such as Bayley's to be the gold standard and to be what everyone should be using in terms of doing neurodevelopmental assessments. Later on, I'll just go a little bit into details of why the lack of tools in low and middle income countries really contributed to health inequalities for children across different spectrum, whether it's research or clinical care. With that position, I was able to move into a very beautiful part of Kenya, right by the Indian Ocean, to work on developing a set of tools that could really be used for children between 0 to 35 months of age. And for them, this was a priority for two reasons. One, as an institution, their key focus was infectious diseases. And they would find that while children came out from hospital after treatment, they really did not have a way to monitor how they were doing in terms of their, long-term neurological sequelae, but also there were various interventions being given in terms of prophylaxis. And yet they had no way, well, they could look at mortality and say, yes, the child has survived. There was hardly any culturally appropriate measure to say, has the child survived and is the child thriving? Or what are the neurobehavioral sequelae that follow that infectious disease? Or what are the priority integrated intervention this child would need beyond just medical care if there was any brain damage? One may ask, there's quite a lot of measures out there that can be used. So why can't we have, why couldn't one just go and get some of the measures that were considered gold standards? Some of the settings we work in, we find that the populations have very low literacy levels. So skills that require parents to have a lot of background educational knowledge to be able to fill in themselves would be difficult to implement. But also quite a number of our parents experience high poverty levels. In Kilifi, almost 70% of the families would live below poverty levels. But also you'd find that some of the, and this may look very minimal to someone who's not worked with children, you go in and you give these very fancy toys. The children are not used to them. It doesn't mean children in these settings don't have toys. As you can see from this picture, they do have many homemade toys. And especially almost 18 years ago when I was doing my PhD, the shop-bought toys were very few. So when we used those in assessment, it was very difficult. We would also find that some of the tasks would really be new for parents to be able to respond to. But also an important aspect about the way one would look at assessment to really be able to look at whether a child has a disability or neurodevelopmental disorder is just the fact that many parents in our setting live in multiple caregiving contexts. So you'd find that there are tasks the parent would even want to ask a sibling or an aunt to be able to contribute to that assessment. So in developing tools that are for this setting, we had to really think through about the cultural context and how are we able to develop tools that are appropriate for this context. So we were able to develop a set of tools. One that has been used a lot is the Kilifi Developmental Inventory, which really looks at psychomotor development. It uses locally available materials. It can be implemented by lay workers. So one of the key gaps in the areas of neurodevelopmental assessment and in the area of disability for us is really the delay in identification of children with disability, or children who are delayed. And part of the delay is lack of experts. So being able to develop tools that can be implemented by people who are not having a master's in psychology or who are highly specialized really helps in terms of scaling up the tools and ensuring more children can be brought into the clinic and for care early enough. And also we developed tools that can be used in the fields and in the clinics. So, in many high income settings, parents would naturally take their children to clinical settings for assessment, for identification, for care. In some of the rural settings we work in, you need to go into these households and be able to really assess children in those settings. Because either parents don't come to health facilities, some of these parents, the health facilities can even be 20 kilometers away from where they are, making it a huge burden. So by having tools that can be taken to them, what we do is really to be able to, take to them care and reduce that gap in terms of identification for children who need care. But also, we developed our tool to be fully open access and open source for people to be able to use, because it was one of the earliest tools to be developed in this field. So by being able to make it open access to be used by many people, what it allowed is for people to critically look at it, to enhance it, and to innovate on it. And also we were very keen to make it open access because quite a number of the neurodevelopmental and psychological tools are, pay for use. And we found that this pay for use becomes quite a huge burden and a barrier for access to care for many children and families in low and middle income settings. I would say over the years, what we are really proud of having done this work is not really how many people have used the tool, but how we've been able to contribute to the global dialogue about open access tools, about culturally appropriate tools, about ways we can enhance identification for children and really be able to ensure more and more children access care early enough, because we know from the evidence is that the earlier children are identified, early identification leads to early intervention, which contributes to better outcomes for the children. I think at the moment, one of the key outputs from this discussion is WHO has put a team of people who have been able to put together the global scales for early development. This would be a tool that can be used to assess children globally, because it has not been developed with one context in mind, but has really looked at the effort from different countries, from different regions, to be able to develop something that is open access, that can be used to track children, and can really also be used to track the extent to which we are achieving the sustainable development goals for ensuring children thrive and develop. So you can see that my journey to the area of global health really started from education, and we've really been able to merge both educational needs and health needs in the way we address our work. So we have moved, in my career now, I have moved just away from the tools to look at other priorities within the field. One of the key priorities is really developing interventions that are community-based, that can help parents and children access services. So for instance, as we have been able to improve our identification of children with disability, one of the key gaps is care for them. And we know that globally, really children with various neurodevelopmental disabilities, whether you're talking of autism, intellectual disabilities, ADHD, sometimes there is a huge gap between when they're identified and access to service. And therefore, we are working very closely, for instance, in a project which we call SPARK, to develop community interventions not just early identification, but pathway for cares within the community. But also within this project, we are doing one of the largest RCT for the WHO developed program called the Caregiver Skill Training Program. Yeah? The aim of this program is really to train parents to be able to learn skills to enhance their children's communication, but also to be able to enhance their children, to be able to handle challenging behavior for their children. Our hope is that as parents develop more skills on how to handle their children and to enhance outcome for their children, it will be easier for children to transition from the home environment into the school environment. But also some of the work going on within, some of the key pieces of work for me right now is the Uzima Data Science Hub, which is a collaboration between Aga Khan University, Cambridge, and University of Michigan. So really for Uzima, one of the key things we are looking at is how to harness the power of data science to really be able to come up with tools, to come up with models that can be early warning signs for poor mental health, but also maternal, newborn, and child health. So I would say my career has really traveled around the area of early identification, early intervention, but also how best to develop resources that are community-based. One of the things throughout my career that I've found really important and interesting is the issue of capacity building. Yeah? I will talk a little bit more about this, but you find that within low and middle income countries, quite a number of the research is led from outside, if I may use the word, and not with any bad intention, but it's really key if we are going to make an impact, if we are going to make a lasting impact within communities, that we have work that is led and generated within the communities, that we are able to build careers for researchers in low and middle income countries so that they can actually look at the priorities in the settings and be able to develop equitable collaborations. So at the moment, one of the key things we are working on and setting up is a consortium, which is called the African Leadership for Measuring Brain Health in Children and Adolescents. And this consortium would involve 4 African countries with collaborators from UK and US. And our key aim is really to advance the science of brain health by doing high quality research around, measurement of brain health, looking at issues around how neurobiology and neuropsychology. But a key component of it is to build the scientific leaders, the next neuroscientists from Africa. And therefore, this is one of the, it's just been recently funded, less than maybe 2 weeks. And we are hoping this would be one of those key milestones in ensuring that we really contribute towards reducing the gap between, the number of researchers emanating from the African continent. So one of the things, as I've reflected on my journey, one of the things I've had to think about is what are really some of the critical gaps in terms of global health equity. And from my perspective, there are quite a number of gaps, but one of the key ones is the few centers of excellence in low and middle income countries that are really able to generate knowledge, translate and disseminate this knowledge, but also train experts in knowledge generation and knowledge translation. And in thinking about this, I've put down their context, because I feel that while we can have quite a few good centers that are based outside, our local settings that can contribute towards the generation of knowledge, dissemination of knowledge, but having centers that are really local, driven by local aspirations and local experts, or collaborating with people from outside the setting, really would contribute towards sustainability, towards ensuring that the work we produce is relevant and it's acceptable within the setting. Yeah? So in thinking about the collaboration we have with the Center for Global Health Equity, I would hope that this collaboration really contributes towards building a center of excellence within Aga Khan University, where I'm currently based. So what are some of the key lessons I have learned in my journey? And I don't know if I mentioned this, but in terms of the last 18 years, I've been very privileged to work in Kenya, to work in the Netherlands, to work in UK, and to have collaborators across the globe who have been able to contribute really to my career development. And I think one of the key lessons in this journey is mentorship. You know, especially for us who are coming from settings where there's really minimal resources, getting a good mentor who is able to guide you through the process, or a good set of mentors. Sometimes you get one good mentor, sometimes you get a good set of mentors, can really help. So for instance, my professor in the Netherlands was the kind of mentor who, if he had of an opportunity at WHO on something on low and middle income countries, you'd say, oh, Amina, come, let's go together so that you can meet people, you can network. He was the kind of person you would go to and you would get career advice, including telling you this is going nowhere, but in a very respectful way, not in any way meant to make you feel less important. So I think good mentorships have been very key in building my journey in global health, but also equitable partnerships. I think this is one of the key things people really struggle with in terms of growing in the field of global health, because sometimes the partnership can become inequitable when one partner has all the resources and the other one depends on them. But the way I've been able to build partnerships, and the partnerships are found very useful, are the partnerships that acknowledge that each of us brings different resources. Sometimes the resources are financial, sometimes the resources is the local knowledge, and the energy people bring into a partnership can make a big difference in building the careers and ensuring the global health field has better equity. But also for me, I think important is capacity building for institutions in low and middle income countries. I think there's been quite a lot of investment in terms of building individuals, which is great. The problem is sometimes individuals do not come back to work in the African setting. And one of the key reasons is that for them to really be motivated to relocate, to come back, part of it is, the assurance that there are institutions, there are systems in which they can work and build their career and be able to thrive. So I think building and, strengthening institutions so that people from low and middle income countries can actually be able to build their careers in these institutions is key to really a thriving, career in this setting. But also the way I look at this is not like a one-way street. Capacity building for institutions for low and middle income countries would be a one-way street. I feel there's a lot to be of benefits, even for institutions in high income settings, when they have strong partnerships with the institutions in our settings, and they can bring their faculty, their students and others to learn from our settings and to really be able to build their careers. So I think I will leave it at that. I feel my journey in global health is just really developing, and I'm excited in seeing how it all grows and matures. Thank you.
Thank you very, very much for that talk, Amina. I wish the camera would have been on, because my head was nodding the whole time. Every time you said something, I was like, yes, that's great. And I think, for myself as a fellow psychologist and someone who's worked in Kenya, you raised some really critical points that I hope people really take to heart. The value of culturally appropriate measures is so critically important because so many things are really developed from a Western perspective. And so, if we're measuring things developed under standards that in a totally different context, like you said, we're not going to be identifying true challenges, and also we may be pathologizing different things that are normative within the Kenyan context. I also loved what you said about the open access. I think that's so critical. I'm saying that all the time in public health as well. It's like we should be giving things away. We shouldn't be charging to use a survey or to use an intervention. And I think that especially if we are going to talk about health equity, we really have to talk about health equity at multiple levels and making sure people have open and easy access to those instruments. The capacity building comments that you talked about, again, 100%. And I think that's one of the issues I'm concerned about too, as someone from the US, is making sure that when we have students or other folks that are engaging in global health work, that they need to stay in the background, because we are guests in your country and your community, and you invite us in, and that's a privilege. That's a real privilege to be able to come in, and we need to make sure that we're helping to build capacity, but then also share capacity too. We're learning from you, you're learning from us. And so I'm really glad you brought that up. And I especially like the idea of building the capacity of organization as opposed to just individuals, because I agree there's a lot of focus and a lot of resources that are put into an individual. And then what we see, like you mentioned, is brain drain, because then those people end up going to another country. And then we lose that opportunity. So thank you. And also congratulations on the consortium. Hopefully when I'm in Kenya, we can talk more about that. It sounds like a really great opportunity. So this is the Q&A session. So as Tanya's posted in the chat, if people could put their questions, and I'll read those to you, Amina, so you don't have to try and look at the chat and talk at the same time. So we do have a question from Pim Browers. With respect to the data science and the drive to harmonization, how do you balance that with culturally or locally adapted measurement?
Thank you. So that is has been quite a discussion in terms of how we balance global and context relevant measurements. And I think it's one of those things that is ongoing. So I can give an example of a neurodevelopmental assessment or even a mental health measure. So for instance, with mental health measures, there was quite early on in my career, there was quite a lot of debate around context relevant local measures. And people did a lot of work to collect data. And I think the value of that work is that people have reached a consensus that quite a number of it was about the methodology of how you ask it. The methodology, ensuring you don't use idioms that can't be translated. Yeah? So over the years, people have actually come up with really good guidelines on how to do proper translations, proper adaptations. But actually now people are also coming up with really good guidelines on how to harmonize scores across different measures. So like I know in terms of neurodevelopmental assessment, right now, one of the key jobs that are going on in the global scale is to come up with a D-score, a score that can interpret different test results in a very similar way. So I think this is an ongoing task, but I think we got now enough data from different contexts, and we got technology, advanced technology, to be able to really get to a point where we can harmonize data, but it has been collected in a way that is relevant to the context it's in.
I mean, can I ask a follow-up on that? Because
yeah,
this is something I'm very interested in as well. I'm also wondering about, since when we talk about psychiatric disorders, mental health challenges, those are socially and contextually determined, right, and constructed. So we use the ICD, the DSM. What are your thoughts on that? So in using measures like the PHQ-9, we know has been used a lot globally, but is the understanding and conceptualization of depression the same in Kenya as it is in the US? So what are your thoughts about that when we're talking about measuring phenomena that are socially constructed?
If I look at the evidence, I think there's a lot of similarities. There's quite a lot of universality, even where there is contextual issues. Yeah? So my advice is usually you need to test this. So two things. One is to really test what is universal and what is not. For instance, for us, PHQ-9 has generally worked really well. But before we could use it, we really did carry out a series of focus group discussions. We did ethnographic work. We understood what are the barriers. And one of the key barriers was actually the method of administration. When you take a questionnaire that is meant for literate people, has 4 very long sentences, and you administer it exactly that way, people aren't going to understand you. So I would say there's quite a lot of universality, yet one has to think of the context and make the necessary adaptations.
Yeah, that's an excellent point. Another question, they said, really appreciated your emphasis on culturally appropriate and open access tools. How can researchers best incorporate these approaches in the early phases of their own projects? For example, are there some concrete steps they can take to work towards these goals?
Yeah, so thank you. So there is actually guidelines on how to do adaptations of tools, how to develop. So I guess at the start of my career, there was almost like this nature-nurture argument. It's either universal or cultural. I think now people have reached a point where they say, okay, don't reinvent the wheel. First see what is available, how does it work? So the guidelines is to do some work to understand the concepts in the field. So that would involve quite a lot of qualitative work, and also do really proper adaptations and cognitive interviews, and then test reliability and validity. Now, clearly, not every researcher can do this. But also, if you come to a country like Kenya, where 10 or so people have already done it and found it's working, then one wouldn't need to do it. So usually with my students, I would tell them, before you use a tool, go do a nice scoping review on the tools that are available. Look at the reliability, validity, look at the cultural context where it has worked and not, then let's make a decision based on the existing evidence, which steps to take.
Thank you. And there was a question related to reliability and validity of the scales that you've developed, and I'm wanting to know if you could share some resources with folks about that. So I guess maybe that's something we could follow up on.
Yeah, so basically the reliability and validity of the tools are really good. And I think we have a few publications looking at the internal consistency, but even predictive validity. We followed the children over the years. One of the things I've tried to do is not to become like a salesman. So I've developed this tool, and so I think since I did this work a few years back, quite a lot of other bits and pieces of work have been done, and especially the work led by WHO, which has looked at tools and data from almost 8 countries and put that together. So I'm more keen now to discuss ways in which, the global efforts can really be advanced.
Right. Yeah, I'm glad you also looked at predictive validity, because all too often people look at really just looking at internal consistency, reliability, and then are making jumps toward validity. And so that's amazing that you've been able to do that. There was another comment. Thanks. I think this is from Amy. Thanks for sharing your experience as a Muslim girl pursuing a university education with limited choices. Do you think that circumstances have changed in terms of educational opportunities since you were a student? And are there efforts we can make as educators to further improve that situation?
I think a lot has changed in my context about, education for Muslim girls, at least in Kenya. I know there are places where this is actually going behind, and that's a bit sad, but a lot has changed. I think there was quite a historical reasons why fewer Muslim girls were getting into the university, but now the government, I think with the new constitution, there were allowances for people to practice their religion within schools. There's been more encouragement for parents to take children to school, including even punishment in some settings for keeping girls out of school. So that has changed. But I think, yes, there's a lot more we can do. For instance, in the new consortium we've been funded, one of the key things is we are going to have a school engagement program for girls. So not just Muslim girls, but girls in general. And this is really to encourage girls to get into science, stay in science, and move into science leadership. And we think starting from when girls are in high school, exposing them to some of the neurosciences and exposing them to role models. Females who have grown, in their career in science can contribute to this.
Good, great. So there was another question. What needs do we have here in Kenya for access to healthcare and quality of healthcare? And why do you see AI as a powerful tool to address those needs?
So I think one of the key needs is just a shortage in experts in certain fields. So there are really many parts of Kenya where people have to walk long distances to access healthcare. But actually, when they need to access certain healthcare, health facilities, then they're not even able to get specialized care. How can AI help with this? I think some of it would be in early identification. So for instance, one of my students has done her project on radiology, lung. Now, let me just say I'm not an expert in this, in case I said something wrong, a disclaimer. But so the point is, if you had so many images and you programmed that, can you come up with an algorithm that can identify which patients now need to be sent to a specialist? That would really reduce the time for diagnosis because there are very few radiologists to read each scan separately. So I think there are very many settings in which if we are able to use AI to really be able to cut down the wait time, the amount of time people are depending on the few health resources for identification, for care, I think that would be fabulous.
Okay, thank you. There's a question here from Joe Kolars. Any observations regarding your experiences in improving mental health that should be applied in high-income settings such as ours?
So I think from Africa, one of the key things that I'm seeing coming up is really a strong need to avoid medicalization of mental health. So like quite a few innovations are now focusing on how can we have preventive measures. And quite a number of these innovations are looking back at some of our cultural practices. I can give an example of the famous friendship bench. Grandmothers sitting down, talking to women, who are either pregnant or have just had children as a way to support. And that will not be an answer for every person, but could probably reduce, one, the number of people who have to go to specialists, but also avoid unnecessary medicalization of mental health if we can use, socially available systems to provide support and to enhance and promote mental health.
Great, thank you. Yeah, and I love that. And I get frustrated sometimes with that term reverse innovation because there's innovation on both levels or all levels. And I think we have a lot to learn, from each other. Another comment, you mentioned that your current career was not your first choice, but now it is your last choice. What advice could you share with students or early career colleagues who may wish to move into the field of global health from a different field?
One of the things that sometimes is frustrating is people really go into either research or certain fields because it is fancy. It's stylish. It's what everyone is doing. When I went into early childhood and neurodevelopmental assessments, really, it was the least important topic to everyone. Because if you remember during the Millennium Development Goals, everyone was focusing on reducing mortality. But this is where I had a passion, contributing to early identification and intervention for children with delays or disability. So I would say one of the key areas of success is really just choosing something you really believe in and not trying to move with what is currently in style that everyone is trying to do. Now, the other thing is really, I think for early career researchers is getting a good mentor. And I know sometimes we think a good mentor is the most successful person around, but actually a good mentor is someone who has the time and the will to invest in you. So someone may be willing but does not have the time to invest, or someone may have the time but is not willing to invest. So really finding the right mentor, I think, is very key to a successful shift into this career.
Great, thank you. And a related question from Tony Antonucci was first thanking you and talking about how you hit so many really great points. And she was asking if you had any hints or advice for young people who are beginning their career. So she has a capacity building project in Cote d'Ivoire, and their emerging PhDs are now asking for advice about next steps.
So I think some of the important, of course, next steps is about finding mentors. And usually when I'm talking to my students, I tell them, when you find a good mentor, you can't waste an opportunity. Quite a number of people sometimes get an opportunity and don't put their all in it, and therefore the opportunity slides away, and they don't make the most of it. So just say, like being persistent in the field you're in, trying to get the right mentors, but when an opportunity comes, making the most of it.
Okay. We have a question from an MSW student, Joseph, who asks, how do we best balance open access and economic feasibility of projects? Would public-facing educating and showcasing of findings be enough?
It's an interesting question. The problem with sometimes open access, open source is that quality can quickly go off because no one is monitoring it. No one is giving incentives for it. So I think right now, public dissemination sometimes is not sufficient. Because for instance, in this specific field I'm talking about, when you find there is an assessment tool where you have to pay maybe $10 for every child you assess, it just means it will never be used in public hospitals in our settings, but also it means, let's say, PhD students. I know a specific field where our PhD students can't publish, largely because the cost of getting them, reliability, was way more than we could afford or could sustain. So I think just public dissemination is not the way to go. I have seen situations whereby people have gone for really large projects needed. People have gone for funding to support keeping it open access and open source. I would say, or maybe social enterprise, whereby a small fee is able to be charged just to maintain it. But I think really putting material open for more people to use is the way to advance science and to really cut down on the inequalities in terms of access to services.
Okay, great. We only have about 5 more minutes for Q&A, and there's a lot of questions, so I'll try and get through as many as possible. So the one question from Bridget O'Connor is, do you have any suggestions on how we can make connections with teams, researchers, clinical groups that are looking for collaboration? I'm part of a clinical genetics group that is very interested in global health, equity, and training, and are regularly looking for ways to collaborate with groups that have a particular need that we could support, recognizing too their Western perspective of need isn't what may be needed on the ground.
I think one of the key ways is really forums like this, being able to talk a lot more about what people do and how we work together. I think that really can help in terms of building collaborations, because actually, like today, I haven't talked about our genetic works and the kind of things we are currently doing in that field, So I would say a key one is more presentations, more meetings, and just open discussions on what people are doing.
Okay.
But also now there are databases, I think, curating what people are doing that could also be useful.
Great. Okay, thank you. Question, comment from Rama Musalia. Says, Dr. Amina, as a fellow Kenyan, I'm truly proud of the really great presentation and conversation. My question is simply, number one, if you could speak more on the efforts underway to establish local centers of excellence, focus on training experts in knowledge generation and translation, and then 2, what challenges, opportunities do you see for scholars in the diaspora seeking to get involved in these efforts? And then a PS, Hongera Sanadada, which I probably pronounced wrong.
You didn't pronounce it wrong, you got it right. So 2 things. I will be biased, but at IHD, the Institute for Human Development at Aga Khan University, where I work, and many other institutes within Aga Khan, we are very keen to build centers of excellence. So please get in touch, let's talk. I think there is a lot to gain both ways in terms of doing this. In terms of scholars in the diaspora, actually, one of the key challenges is just the identity. Recently, we were discussing quite a large collaboration we have, and we have someone from South Africa, but based in US. When she sent an email, then she was told, oh, are we having the US lead this program? We thought it was led in Africa. And she was like, I'm African too. So I think it's a question of identity. And one of the things I would advise, and really a possibility, is to get affiliations with institutions at home, because then you contribute your skills, you're able to, to learn more about what's happening in the context and to contribute more meaningfully. So even when I was working in Netherlands and in the UK, I always kept my home institution affiliation in Kenya, which really allowed me to even apply for funding that needed someone who is based in Africa to be able to access it.
There was a comment from Pamela Wadande, who said avoiding medicalization of mental health in low and middle income countries is more critical because then resources can be used where they're most needed. So I think that's an excellent comment. Another question from Joe Kolars: what do you think are the ingredients necessary for a good collaboration between Global North and Global South partners?
And that is actually Akbar asking.
Oh, that was Akbar, sorry. I just saw that. Thank you, Akbar. Sorry for messing.
It's mutual respect and open communication. So I think if people mutually respect each other and value the contributions they are bringing to the table, it builds a good collaboration, but also open communication. I always say this to my colleagues in Africa, our culture sometimes does not allow, encourages us to be polite, and especially if you're a visitor, not to sound rude. But if we don't negotiate the rules of the game early on, then people start feeling resented, they start feeling left out. So I think for me, if people can openly communicate and they can have mutual respect, it's really a recipe for a good collaboration.
Thank you. I think that is an excellent point to end on. I want to just thank you, Amina, so much for your amazing presentation, your incredible thoughts. I'm looking forward to collaborating with you in the future and can't wait to see you in Nairobi. And also thanks to the audience. These were really amazing and incredible questions and comments, and it was great to see such engagement from the audience. So I think this is a really amazing way for the center to end our series. And so now I'm going to turn it over to Amy Conger to wrap things up. Thank you.
Good afternoon, everyone. Gary, thanks for being such a warm host for the seminar. And Amina, we so appreciate your expertise and your partnership and for opening up and sharing your story with us today. I want to wrap up with a couple announcements for our faculty friends. We want to remind you about a global health commercialization competition. And this really follows nicely to what Amina shared with us about the value of locally sourced technology, tools, solutions. So there's information up here. If you're interested, there's still time to apply by April 14th. And we're going to share these details with you in the chat. But it's a chance to work with collaborators in lower middle income countries to launch solution-oriented work in local markets. The second item that is coming up is we're looking forward to the Consortium of Universities for Global Health annual conference. That will be the in-person component in Washington, D.C. in mid-April. And there will also be some virtual satellite sessions. Important to note for everybody on the call that many of those virtual sessions are free of charge. So we encourage you to tune in and learn from colleagues around the world. The center is very pleased to maintain an institutional membership in CUGH so that all of our community members can benefit from that membership and take part in professional development, sharing of ideas, and conferences. And here in Michigan, we are looking at the close of our winter semester. So along with final exams and the end of classes, we're also hoping for some sunshine soon. And we can't thank you enough for following us this academic year throughout this seminar series, and Amina for bringing such a great finale to the series. Please keep in touch with us via our website, our newsletters, and following us on Twitter. And we're wishing you all a restful end to the academic year, and we look forward to picking up speed again in the fall. Thank you, everyone, so much.